Okay, so now that we've put the pieces of the puzzle together as far as concepts, let's look at cardiovascular assessment and then the role of the nurse into the cardiovascular assessment. So, if you remember from our last lecture, we said that cardiac output equals heart rate times stroke volume. Heart rate is variable. Normal heart rate 60 to 100. Stroke volume somewhere between 60 and 100 as well. And both of these will have a direct effect on how well you are perfusing. When I'm looking at airway, breathing, circulation, so I'm looking at priority interventions for a client with decreased cardiac output. And that's one of the reasons why airway, breathing, circulation is so important. If your client isn't perfusing, they're not getting enough oxygen. It's important to have supplemental oxygen. If your client's not breathing effectively, they're going to have decreased oxygenation. It's going to make their heart work harder, work faster. It's going to put your heart under increased stress. You're going to have to give them more oxygen and more volume. Then obviously, if it's a circulation issue, you have either hypotension, hypertension, you're in shock, you're in hypertensive crisis, whatever it may be. We do know that your body compensates fairly well for these things, right? But there's only so far that those compensatory mechanisms will go. They'll work up to a certain point, and then you will end up in shock. For me as a nurse, I understand that any tachycardia is an early indicator for all clients that there is a problem. And it doesn't have to just be cardiovascular. You could have underlying asthma that you aren't aware of, but you have a resting heart rate of 109. In the real world, am I worried about a heart rate of 109? Not so much. But I do understand that long-term consequences of an elevated heart rate increases your risk for heart failure exponentially. I want to make sure that I'm getting accurate measurements of blood pressures. A lot of us, I can't tell you how many times I've walked into a room and the client is using a blood pressure cuff that is either way too big or way too small. I've seen nurses that have been nurses for years not align the blood pressure cuff in the correct way. Again, this is part of the process of active thinking and active clinical judgment when you realize that you have to be looking at the whole clinical picture. The wrong size blood pressure cuff is a huge risk for our clients, especially if they're in a step-down unit and we're doing more invasive things for that client. We talked a little bit about orthostatic hypotension, right? So just as a refresher, we understand that these blood pressure changes happen when we have changes either sitting, standing, or laying, and it's usually the blood pressure has to have a drop in 20 millimeters per mercury and an increased heart rate. So you see all of a sudden those compensatory mechanisms, the blood pressure is dropping, but it's trying to compensate by that heart rate going up. Anybody that is at risk for orthos, I always want to make sure that it's a big safety piece, because that is a safety and infectious control type of question for NCLEX. I want to make sure that they have their call light, they're asking for help when getting out of bed. I want to make sure that I'm teaching them that they put both feet on the floor before standing. If they're truly on bed rest, they need to stay on bed rest. We've talked about a pulse pressure, right? We said a narrowed pulse pressure or a widened pulse pressure are never great things. Usually it's going to be associated with some sort of shock or dysrhythmia or stenosis. Could be congenital. And initially we'll talk about that with congenital heart disease a little bit. We've talked about the ejection fraction. Again, we're going to use 60% as our number. And we want to look at heart failure. When I think about heart failure, I want to look at BNPs, pro-B type natriuretic peptide. Doesn't have to be a pro-BNP, it can just be a regular BNP. We will have different numbers though when we get into diagnostic studies for those. I want to think about the possibility of doing a transesophageal echocardiogram. So people are either going to call it a TEE or a TTE, or they may just say echo. I have certain goals because blood pressure is so huge in the cardiovascular system that I want to make sure that my client's blood pressure maintains somewhere close to what their baseline may be. Especially if that client has a history of aneurysm or other like renal comorbidities. All that is going to affect perfusion, right? I want to make sure that I'm assessing for side effects of the medication. In our last lecture, I showed the telemetry monitor that was showing a heart rate of 38 beats per minute. Okay, did we cause that? I want to encourage lifestyle modifications. Big issues there is probably by the time we realize that they have issues with their blood pressure, it's been happening for a really long time. Most of us aren't lucky enough to get caught when our blood pressure goes to 125 systolic consistently, right? We ignore the information that we have. We ignore the fatigue, the tiredness, the dizziness, the headaches. We ignore all that, and we don't come to the doctor until it gets really, really bad. And by that point, it's probably 160 over 90. And then, okay, we're going backwards here. When we talk about our other comorbidities, we'll talk about what it looks like and how that blood pressure is ultimately affecting your risk for heart failure. And then, of course, any good nursing student, that's you guys, of course, knows that alcohol and smoking should be discouraged. Generally, the way I see NCLEX questions set up, it's always to stop smoking and to mitigate or limit your drinking. Because it's a very hard thing to ask people to not drink at all. It's a very hard thing to not ask people to smoke, but that's what we're going to do. So smoking and drinking in moderation. Stop smoking and drinking in moderation. All right. What about me? What about me? What about the nurse? Well, we have a overall big picture, right? This is your NCLEX category. That's health promotion and disease prevention. It's a very small portion of your NCLEX, but it's one. When I see test results come back to us, I see that a lot of this students will be under that minimum level. It's not a great thing. So we have to teach clients to maintain healthy lifestyles, diet, exercise, take your medications as prescribed, see your healthcare provider when necessary, drink in moderation, stop smoking. Make sure that if you have diabetes as a comorbidity, that we're doing things to keep your blood sugar numbers in range. Blood sugar is a potent vasoconstrictor. So think about all of those ulcers and things that we see on our clients that have diabetes. And we say that we have delayed wound healing. Well, you have delayed wound healing because you're not getting enough blood flow because of the vasoconstriction. So most of the times our clients that are diabetic will also end up with some sort of PAD, peripheral arterial disease. Limit caffeine, alcohol. Caffeine is also a stimulant. It's going to increase your heart rate. It's going to increase your vasoconstriction. Stress will do that. We talked about smoking. Nicotine patches are a great alternative. We just got to convince the clients that it's a great alternative. And then diet is always a big one. I don't get heavy into diet because you've already had, at least for my students, you've already had diet and nutrition as its own little section. But I think most of us realize that we want to be on some sort of cardiac diet if we have a cardiac comorbidity. So we're going to limit the sodium and limit that fat. We are going to use a lot of subjective and objective information. And I always think like this. My clients tell me that they are short of breath all the time. what do? I'm running down the halls because they've hit the call light and said, I'm short of breath. I'm probably not running down the halls, right? Going to go and assess the client. They're going to tell me how they feel. I feel like it's hard to breathe. I'm going to look at their pulse ox. Their pulse ox is going to say 95, 96. There are a lot of other things that could be causing this anxiety, or this what they perceive as difficulty breathing, versus me going into the room and looking at somebody who is struggling to breathe, that I don't get past 15 seconds and their respiratory rate is already 20 plus, that their SpO2 is 74. That's subjective and objective information. We have to use both of those pieces to provide an adequate picture for what my client is experiencing. So we see things, we hear things. It's inspection, palpation, auscultation. It's the normal nursing procedures that we do. All of it is going to help me validate information, what I see in their health history, to develop a plan of care and look and help me evaluate the effectiveness of my interventions. If you came in with hypertensive crisis and I'm giving you sodium nitroprusside, I better be taking frequent blood pressures, because that is going to be my objective information. Versus if you come in with blood pressure and I'm giving you metoprolol and lisinopril and your vital signs are scheduled for Q6 hours. All right, you can see that there's not a as big a need of that immediate feedback as it would be for somebody on a nitro drip. So when we're doing those things, it's important that we look at the primary and the secondary assessments. And we see new nurses struggle with this because this is really just part of prioritization and delegation. When I'm using that subjective and objective information, I'm still going through the process of, okay, airway, breathing, circulation. If you come in and you tell me you're having chest pain, my primary focus, my primary assessment is going to be focused around that chest pain. And I'm going to do assessments, and I'm going to do interventions, and I'm going to complete evaluations that revolve around chest pain before I move into a secondary assessment. And I see a lot of people, they want to come in and the client says chest pain, and they kind of, okay, well, let's start going through your hair and looking for lice. And I'm like, sitting in the back, what are we doing right now? You know, the client didn't come in because they had lice. The client came in because they were having chest pain. So we finish that piece before we move on. So once you do your airway, breathing, circulation, then you're going to move on to your secondary assessments. You're going to look for disability and exposures and do your examinations, your full head to toe, get that full set of vital signs. You're going to give that emotional support. You're going to complete that history. And then you can flip them over and look at their backside and all that great stuff, right? Interventions, inspections, all of the great stuff as far as a assessment is conducted. So always start with airway, breathing, circulation, and then finish up. If you have to come back to finish up that secondary one, that's not a big deal. So things that I could ask about and help remember is I'm going to get a sample of their health history. What symptoms do they have? What brought them in, right? What allergies do they have? What medications did they take or are they taking? Both. Do they have a past medical history? When's the last time they had anything to eat or drink? And then what were the events leading up to it? You know, I've been having indigestion for weeks now, and all of a sudden that indigestion turned into crushing chest pain. Okay, that gives me a lot of information just talking to the client like that, if they can talk. So remember your sample. All right, so break it down. Hey, any relevant history of chest pain, any shortness of breath, etc. Do you know, or have you ever been told that you have heart failure? You're going to be surprised at a lot of their answers. Current and past use of medications, prescribed and over-the-counter. There are a lot of medications that interact with the cardiovascular system. A lot of medications that clients refuse to take, even though they've been prescribed. Or sometimes it's just circumstances, people that can't afford their medications and they're trying to do the right things. It's just they're in a bad situation and can't get them done. Any treatments, past surgeries, hospitalizations. Hey, do you have a cardiac history? Clients will say, no, all the time. And then you look through their chart and all of a sudden, they had a MI 10 years ago. Oh, well, I didn't think it was that bad, so I don't have a cardiac history. It's not hurting now. Well, I need to know that stuff. Lifestyle, family history. You're going to do current weight and weight history when it comes to heart failure especially. And then ask them about what they typically eat in a day. If they do complain of pain, whether it be chest pain or not, you have to understand the concept of OPQRST. I do see where it's onset and timing are basically the same thing, but this is how I remember it, because this is how we're going to look at this PQRST for dysrhythmias, and then the O helps me differentiate in my brain when I'm talking about it. So O, onset. P, what provokes it or makes it better. The quality, is it crushing, is it stabbing, is it sharp, does it radiate anywhere, or is it localized on a scale of 1 to 10 for that severity. And then timing. Oh yeah, every time I go out to the garden, I have chest pain. Okay, well, what are you doing before you got to garden? Are you taking a prophylactic nitro? Have you been prescribed something for chronic stable angina? So anytime they complain of pain, make sure you're going through the process of OPQRST. I know it doesn't look like it the way EPIC is set up, but those are basically the questions that you're asking them on the pain scale. I'm going to ask them if they have any issues going to the bathroom, right? Bowel elimination, going pee at night. We have these things that are telling me about circulation. Now, that's why I worry about problems with the urinary system. It is probably one of the biggest concepts missed in the cardiac section. Cardiovascular has a huge impact on intake and output because of the effect of perfusion to your kidneys. We want to look at their I's and O's. Again, it's the number one missed concept on the cardiac exam. Nobody ever wants to tell me to look at I's and O's. Talk about paroxysmal nocturnal dyspnea. If they have any sudden waking up in the middle of the night. How many pillows do they need for comfort? That could be respiratory, that could be cardiac. It's just good information to have. We talk about the genetics, all that good stuff, gender, race, age, medications as far as sexual performance, any kind of stressful situations, and obviously what are their values and beliefs. And that is a part of the NCLEX now, values and beliefs. All right, we've talked about things to look at. So when I walk into a room, I'm looking for the way that client is breathing, the way that they're sitting. If they're turning their head to me, I'm evaluating how well they're responding. What's their LOC? Symmetrical expansion with respiration. I'm expecting for palpation that they don't have any thrills or no weak and thready pulses, that the PMI is where it's supposed to be, so I don't have any cardiomegaly. I'm expecting to hear S1 and S2 with a normal rate and rhythm, no murmur. We talked about a murmur being turbulent blood flow. And then no additional heart noises. Even if you can't identify it's a murmur, if you hear something other than lub-dub, then you know you have an extra heart sound. We talked about this from the first slide. This is all physicians take money. We've talked about the atrioventricular valves versus the semilunar valves. This is a pretty common thing to see as far as a hotspot question is concerned. Where should the nurse auscultate for a client complaining of chest pain with the diagnosis of aortic stenosis? So if I want to know about aortic stenosis, I'm obviously going to choose the A, the second intercostal space on the client's right sternal border. We've talked about murmurs, turbulent blood flow, pericardial friction rubs. It's going to be a grating noise that you're going to hear with conditions such as pericarditis. You can hear high-pitched, scratchy sounds, kind of like rubbing your fingers through your hair. Down here in the image, we see the normal, it's basically PQRST of the dysrhythmia cycle, but where we would hear those valvular sounds. And you would see that this S1 and S2 are where we would expect them with contraction of the ventricles and relaxation of the ventricles. So kind of when we talk about dysrhythmias, this QRS is going to be ventricular contraction, so you hear closing, and then this T wave here, you're going to actually hear this S2. So one is opening and one is closing. Pulses are a good indicator. Obviously, we said weak or weak and thready are bad. Absent pulses are really bad. Please don't be the person that documents no pulses and then didn't go get the Doppler. We are going to talk about arterial occlusions and significant hypotension or even possible dysrhythmias when we have changes in these pulses. If you have an irregularly irregular pulse, I can pretty much guarantee you that the rhythm is going to be atrial fibrillation. So we do have lots of places that we could check for pulses. Obviously, we have the go-tos. You know, we have the radial arteries, right? Then you have your posterior, and you have your dorsalis pedis, posterior tibia. You have your popliteals. So anytime you can't get a pulse distally, work your way up, right? So keep going this way, and then keep going this way. We talked about how we document these pulses. We already said, again, emergency. If they have no pulse or it's weak and thready, it's a medical emergency. If they do have a pulse, but it's weak, why is it weak? I would expect it to be weak probably more in the distal lower extremities because it's harder to get blood down there if you have vascular issues, or you have normal pulses or bounding pulses. So 1 + 1 could be dehydration, +3 could be fluid volume overload. So looking at absent pulses in our extremities, this is usually in the feet. It's further away from the cardiovascular. It's harder to get blood there, especially when you have history of hypertension or vascular heart disease. Make sure you're checking it with a Doppler, and you want to also make sure you're checking both the posterior dorsalis pedis and the dorsalis pedis and the posterior tibia pulse. All right. When I'm looking at the client from a straightforward position, if they're sitting at a 45-degree angle, I can probably check for JVD. Obviously, I don't want them to have JVD because that's probably telling me that they have some sort of heart failure. And then if I need to, I can palpate a pulse. Please don't palpate both carotid pulses at the same time. Or you can listen for a murmur or a stenosis. But that's more NP-ish type of stuff, you know, nurse practitioner type of stuff. So this is kind of what we could see when I'm assessing for JVD. If I do a little bit of this hepatojugular reflex, I can see some jugular vein distension. Or if I raise their head to the bed and maybe they're having some issues with Kussmaul respiration. So when we're exhaling and inhaling, I see some JVD. As far as the peripheral vasculature, obviously we're going to be looking for no rashes, no swelling, no color changes, especially cyanosis. We'll talk about venous stasis or arterial insufficiencies, but basically I'm looking for color discoloration, or I'm looking for weak pulses or bounding pulses. We'll talk about normal hair loss, pigmentation around the ankles, no clubbing in the fingernails. Clubbing takes a really long time. We want to look at capillary refill. It should be brisk. It should be less than 1 second. I want their hands and feet to be warm and pink, because we know, generally speaking, if you're cold and clammy, that's a circulation issue. When assessing vital signs, I want to be especially cognizant of compensatory mechanism. So I'm looking at an increased heart rate, an increased blood pressure, an increased respiratory rate. I'm looking at that pulse strength. Again, weak and thready is deadly. We've talked about a pulse difference. Possibly, if you do assess that, it's going to be because of a dysrhythmia. All right. So, big picture. Always start with airway, breathing, circulation. All right. Your cardiovascular assessment begins the minute you walk into the room, because you can see how well the client is responding to you. You can see their respiratory rate. You can see whether they're anxious, whether they're gray, their color has changed. Then you can feel them. Are they cool? Are they cold? Are they clammy? Then we're going to do our assessments, and we're going to listen to heart sounds, and we're going to get a set of vital signs. We're going to do all of the things that are going to tell me whether or not my client is perfusing. And perfusion is number one, right? That's what we're always going to be looking for.